people ask me this question when I handle manage the community clinic. Yes, some people have to take both warfarin and aspirin. But not a lot of people. Some people have to take both warfarin and aspirin. Aspirin generally take for the platelet or certain people, certain patients have the AFib, but they don't have additional factors. So they only need take aspirin. But when they have additional factors like over over 75 or have diabetes. So generally the CAT2 score over 2, they should take the anticoagulant instead of take only aspirin. But some people have to take aspirin and warfarin because they have additional condition. For example, people who take warfarin for the AFib, and they have to take maybe aspirin for the stent. People who have the stent in their body, they may have to take aspirin for 1 year or so. Some people have to take the other anti-platelet, like Plavix. So depending on your medical history, your doctor or your pharmacist will review whether or not you should take both aspirin or warfarin. Thank you for your question. Do you have any other further question? Please let me know. Thank you. I am thinking, this is another good question. I think generally for the major procedure or surgery, I would recommend to hold aspirin for 7 days. But you need to check with the heart doctor to make sure they are okay for the how to switch from warfarin to Eliquix. So you can go to Google and type in switching from warfarin to Eliquix or Abixi-ban. You can find uh, about 400,000 results. Okay, but the first few um, website help you to understanding how to switch from warfarin to Eliquix or other direct acting oral anticoagulants. So for Eliquix, we'll switch to the Eliquix when the iron are less than 2. So, excuse me. So, for example, if the patient is therapeutic at the Coumadin clinic visit, I used to have the patient stop taking warfarin about 2 days prior to starting the Eliquix. So, at that time, I had time to send out the medication to the patient. For example, if I overnight, then the patient should receive the medication the following day. Or if the patient pick up the medication at the window at the pharmacy, then the patient have the medication ready to switch to the Eliquix from warfarin. So again, it depends on the iron level, so we can um, have the patient switch from warfarin to Eliquix from the outpatient setting. So if the patient inpatient or hospitalized, then it easy to stop the warfarin and try to retest the iron to make sure it's less than 2 before start taking the Eliquix. It's more easier for the patient to switch to the Eliquix when they're still at the hospital. But if the outpatient management, then you need to like stop the warfarin for 2 days. If the iron at the therapeutic level, and then start the Eliquix to make sure the iron less than 2. If the iron a little bit high, like 3.2 or 3.3, then I would would recommend to stop the warfarin for 3 days prior to starting Eliquix. But what happens if the iron at the really high, like 3.6 or above in the time visit, then I would recommend I would reduce the dose or take a partial dose and then retest iron in 1 week to make sure iron level therapeutic before switching to the allergies. And when the INA at the therapeutic level and just try to hold 1 or 2 days prior to the allergies, prior to starting the allergies to make sure that INA that's the COVID-19 caused VTE, the thromboembolism, venous thromboembolism, the DVT or PE, deep vein thrombosis or pulmonary embolism. You can go to Google, you can type COVID-19 cause VTE. It will show up, about 840,000 results. So the first few results indicate that the patient with the COVID-19 infection might experience an increased risk of venous thrombosis, the DVT or PE. So, and then you can see the most popular website in the medical field is uptodate.com. It also shows that the COVID-19 patient might experience the coagulation disorder. And then in the following website, Boston Medical Journal.com is also show that the patient with the COVID-19 are associated with the venous thrombosis. So, yes, the answer is yes, the COVID-19 might cause the venous thrombosis. So, I have experienced some patients who have the COVID-19 vaccine and they experience the increase of the INA. So the COVID-19 vaccines might increase the INA number. It's not much. It's about between 0.5 to 1. For example, people who normally have INA around 2.5, they may increase the INA to 3.0 to 3.5 after vaccination. So, but it not last long. Usually they experience the INA increase in about 3 to 4 weeks. And after that, they back to the normal target, normal range. So in those 3 to 4 weeks, the patient who have increased the INA due to the COVID-19 vaccines are used to decrease the warfarin dose a little bit, like maybe just a half dose per week to make sure that I'm not outrange. It's not super therapeutic. So, excuse me. So yes, some people have a concern whether or not the COVID-19 vaccine affect the iron level or not. Yes, they they do affect the iron level, but not much. Thank you. So how you switch from Eloquent to Warfarin? You can go to Google and type in switching from Eloquent to Warfarin. You buy about 300, more than 300,000 results from this search. Uh, but the top few website have some very important information for you. The first one say converting the aliquots or this event. They recommend start warfarin and stop this event 3 days later. So this is correct, but it depends on the warfarin level. For example, um, the baseline for warfarin, before you start warfarin, you need to get the baseline warfarin. Okay, and the normal warfarin is usually below 0.9 or 0.9. So around that level is normal warfarin. The people never on warfarin before. But how about if the warfarin level at that time at the baseline very high, like 0.2, I mean 1.2 or 1.3, things like that, and you may need to stop at this event maybe days or so. And then the second option, they say maybe stop at this event and then start the parenteral anticoagulant or the injection anticoagulant. So, like Lovenox, and then warfarin at the same time. So, for some people, they are very high risk of stroke or high risk of complicated situation. So you need to make sure that the patient not have any kind of life-threatening issue. So at that case, you may, if you want to switch to warfarin, then you probably need to make sure warfarin at a therapeutic level. In order to do that, because it takes about 3 to 5 days in order to make sure that I now get to into the therapeutic level. In order to make sure that you need to have some form of injection, like low-level injection, to make sure the patient is not risk of having stroke or dangerous blood clot. So that's about what you need to know when you switching from aliquot to warfarin. But you need to make sure you have the baseline iron, and then based on the iron level, you may need to to make sure when it's safe to stop the aliquots. maybe 3 days later, if you have normal baseline INR, if you have high baseline INR, then you might need to consider to stop the Eliquis a little bit sooner. And then if you think that the patient is very high risk of having stroke or dangerous blood clot, then you need to make sure that you have some form of the injection, like low vein injection, make sure um, the INR level at therapeutic before you stop the low injection. Make sure the patient not having stroke or dangerous blood clot, like blood clot in their lungs. Thank you. All right. So, how do we switch from warfarin to Xarelto or rivaroxaban? This one is a little bit different. Uh, you can go to Google and type switching from warfarin to Xarelto or rivaroxaban. You have about more than 400,000 results. Okay? And for the first few ones, there is some information that tell you how to switch to Xarelto from warfarin. So right here they say from warfarin, stop warfarin and start Xarelto when INR less than 3. You know that for the Eliquis or Bedex, when INR are less than 2, but for Xarelto it's less than 3. Why? Why is different? Because Xarelto is kind of little bit, it has a little bit longer half-life. So when it has longer half-life, means the medication lasts longer, and then it take longer time to get to the peak effect. So when the INR is less than 3, so you you stop the warfarin and start Xarelto. It takes some time for Xarelto to work in your body. So that's why they want the INR less than 3 instead of less than. So, and then similar to Eliquis, if the patient had the life-threatening blood clot or having high risk of stroke, then you may need to consider the anticoagulant injection, like luminol injection. So, I mean, when you want to switch from Xarelto to warfarin, and then you might need to consider the luminol injection to make sure the patient don't have any stroke risk or any life-threatening blood clot. But when you switch from warfarin to Xarelto, then you only need to know when the INR is less than 3. Then, but it's different from the hospital libation and the outpatient patient. So for in the hospital, you may monitor iron now or recheck iron now maybe daily basis to make sure iron now less than 3 before you start the Eroton. But how about the outpatient setting? You don't do the iron now daily basis. How do you plan for that? For me, when the iron, for example, at the therapeutic iron, then yeah, I just tell the patient to stop the warfarin, and I overnight the yellow toe, or I send the patient to the pharmacy window so they can pick up the Yeroto and start the Yeroto next day, the same schedule they are taking warfarin. So when I know the INI therapeutic, then it's between 2 and 3, then I'll say go ahead and stop the warfarin for tonight and start the Yeroto tomorrow. And I know the patient will receive the medication at window, or you have the patient tomorrow via the overnight service. And how about if the iron not too low? If it's too low, then I would just say take half dose of warfarin at their schedule, and then start the Yeroto the next day at the same schedule of warfarin. What happens if the iron not too high? Like 3.5 or 3.5 or 4 or about 3. So if it is above, if the INA above 3.2, then I would just say stop the warfarin for 1 day, and then go ahead and take Yeroto the next day. But if it's 3.5, then I might recommend to stop warfarin for 2 days prior to take Yeroto. If it's 3.6 or above, like 4, and then stop the Yeroto for 2 to 3 days. But if it's more than 4, then I will have to hold the dose and have the patient to come back, in 1 week and to retest the iron and go from there. But I don't. If it's above 4, and I have to have the patient to reject the iron. That's how I switch from warfarin to Yeroto. How to switch from Yeroto to warfarin? You can go to Google again and type in switching from Yeroto to warfarin. You have about 45,000 or 4,500,000 results. So that's a lot, but for the first few results, and learn how to speak to warfarin from Yeroto. So they recommend that you need to continue Yeroto warfarin. You start warfarin and continue the Yeroto together, overlap for 3 days. So you stop the Yeroto in 3 days. Switching from Yeroto to warfarin. Okay. So you start warfarin and then Yeroto, and then stop the Yeroto in 3 days. And so hopefully in 3 days, warfarin start working. Okay, but if the in 3 days you take the I9 level is still too low, like 1.2, 1.3, 1.4, and I would continue Yeroto for 1 or 2 more days and increase the warfarin a little bit to make sure the patient is safe from blood clot. I should that to tell the patient to remember to stop Yeroto as instructed. Some patient they forgot to stop the Yeroto. So that's the main thing. By the patient, you might call the patient. Make sure they stop the Yeroto as instructed. Otherwise, may cause bleeding. So usually for the new warfarin start, you check the iron level maybe twice a week. Monday and then the next iron Thursday or Friday. So I would recommend that you should, start warfarin and then stop the Yeroto in 3 days. And then recheck the INR. If the INR is still too low, then I would recommend continue for another 1 or 2 days. Then adjust the warfarin dose to make sure it's not too high and not too low. And then recheck in about 3 days to make sure the patient is not at risk of blood clot or stroke. And then to make sure the patient is not continue taking both medication, the Yeroto and warfarin. Okay. So if the INR is still very low and probably need to increase the warfarin to make sure it get to the therapeutic level. And have the patient to report any abnormal bruising or increased bleeding risk. Thank you. How to switch from warfarin to Badax? Go to Google and type in switching from warfarin to Badax. You have about 340,000 results. The first few top results, you may have some information. Here, pharmacist.com give you a very quick information. So you stop warfarin and start Adaxa when INR less than 2. So this is general recommendation, but how you apply if you are from the hospital setting. If you work in the hospital, you might check INR daily. So when is INR less than 2, then you start by that on the same schedule, start the warfarin. Badaxa is twice a day doses. You take one capsule twice a day. How about the outpatient setting? Um, if you check the INR and INR is less than 2, and the patient has the outpatient clinic, and you are able to give the patient the medication, the Badaxa, then the patient can start Badaxa at the schedule of warfarin. Stop warfarin and start Badaxa. But when I'm at the therapeutic level, like between 2 and 3, so you have to wait, like hold for 1 day to make sure I'm less than 1 to 2 days to make sure I'm less than for the patient start the Badaxa. But if the patient need to, if you need to send the medication to the patient home, you overnight, it may take one day, and then if the INA is at the therapeutic level, then I need to go 1 or 2 days, make sure INA less than for the patient. If the INA at the time of visit is like 3 point above the level, 3.1 to 3.5, then probably the patient needs to hold more than 2 days, like maybe 3 days. And how about if the INA, above 3.6 or so, then probably the patient needs to come back to reject INA, just hold one or half dose or 1 dose to make sure that INA back to the normal range, and then reject it further notice or further instruction. Depend on the INA level and inpatient or outpatient status to provide best recommendation when doing from different vaccine. How to switch from production to orphan, or from a bigger trend to orphan. So go to Google, and I've been switching from production to orphan. You have about 400,000 folks. Again, when you look at the first few top websites, right here, stop warfarin and start a bigger trend when I'm less than lower limit of therapeutic range, less than 2. Pharmacist.com recommend stop warfarin and start a bigger trend when I'm not. So, in the hospital setting, you can do daily INR. So you check the INR, it's less than 2, then to stop, open, and start the bigger trend. But how about the elevation set in at the time of visit when I less than 2, then probably you can hold the bigger trend one day and then start the Badaxa. If the patient has the medication um, on hand, then you may, when the INR less than 2, stop open and start the Badaxa. If the patient um, doesn't have the Badaxa on hand, like you need to overnight the medication, and like that, it may take 1 day or so to get to the patient home. So you need to, if the iron at the therapeutic level, then you just hold the bigger trend for 1 day or 2 days prior to start the Adaxa. If the iron like 3.2, 3.1 to 3.5, then I would hold open for like 3 days or so to make sure that I'm not less than 2, then start the Adaxa. But if it's greater than 3.6, I would hold the open for 1 day and have the patient come back in 1 week to recheck the INR for further instruction. So it depends on the INR level in order to recommend when, how many days need to hold open in order to get the INR lesson or switching adapt. I'm talking about the Alaquix versus warfarin. So why you need some people take Alaquix or ibixaban versus warfarin? So when you go to Google and you just search for it, Alaquix versus warfarin, you will have about 600,000 results. Okay, so for the first few one, you can find some quick information why they choose Alaquix versus warfarin or vice versa. So the first one from myheart.net, they say Alaquix is shorter acting than warfarin. Excuse me. So Alaquix is shorter acting than warfarin, and the blood thinner effect is quicker gain or loss after about 24 hours. Alaquix rarely requires bridging because it is shorter acting and can be safely stopped a day or 2 before any medical procedure or surgery. Yeah, so it's Alaquix image and the warfarin image here. It's not always the case. It is just general information. I've been working for the Anticoagulants clinic for many years. So yes, Alaquix, you have to take one twice a day. Whereas the warfarin or Coumadin, you take one tablet, one dose a day. So it have a longer half-life, and it take a longer time to get to the peak effect and
get into stable state. So usually warfarin take 3 to 5 days to start working in your body when you just start warfarin, and then it take 1 to 2 weeks to get to the beach. I mean, like the peak, and then it become a stable state after 2 weeks or so. Aliquid is just similar to the low enough injection or enough suffering injection. So Aliquid is the fixed dose medication. Either take 5 milligrams twice a day or 2.5 milligrams twice a day for certain patients. So it works every 12 hours medication. You should take same time every day, every 12 hours, and then the warfarin the same time every 24 hours. Aliquid is very expensive medication compared to warfarin. Aliquid, even though you have a copay, it is very expensive, like $500 per month, and then about 1,000 or more for 90-day supply. Either warfarin is like $10 for 3 months or so, so it's very cheap. Aliquid is a new medication. I think it's available since 2018 or so, but 2017 until now. It's been studied and it's shown that the Aliquid is effective just like warfarin. And for elderly people, it may be convenient. They don't, have to go with the confused dosing with warfarin. Aliquid just take 1 tablet, fixed dose twice a day. So it may be best for a lot of patients, especially elderly people. Warfarin is very complicated in dosing. Some day you need to take 1 tablet, some day you need to take half tablet. It's a weekly dose, but you have to take every day. It's so very complicated. Another advantage of Aliquid is diet. Warfarin might be affected by the vitamin K foods like greens, vegetables like kale, cucumbers, spinach, broccoli, things like that might affect warfarin. Some if you eat more vitamin K food, it may make the iron level go down. And if you eat less vegetable, it makes the iron level go up. So must be stable with vitamin K foods every day. Aliquid is not affected by vitamin K foods, so most of people they don't have to watch for their diet. And another advantage of Aliquid compared to warfarin, Aliquid doesn't require close monitoring. Okay, some people, if you are over 75 and and you have normal kidney function, normal liver function, you only required to test your blood, every 6 months. know. And then for warfarin, you have the maximum they can extend the follow-up is 6 weeks. Okay, so 6 weeks you need to come back to get the INR test, your blood test, to make sure your warfarin level is not too high or not too low. When the INR too low, it means you don't have enough warfarin in your body. When INR too high, it means you have too much warfarin in your body. It's make heart bleeding. So that's why they have to test your INR level frequently. If you are stable, your INR very stable, then you can come back in 6 weeks. But if your INR level is not stable, you have to come back frequently, like weekly or 2 weeks or 3 weeks, depending on your INR level. If your INR level at critical, it means it's too high, like 5.0 or 6. Then you might need to hold warfarin and come back in 3 days or 2 days, things like that. But Aliquid is not frequent follow-up or test. No test required to make sure the Aliquid is enough in the body. No, we don't have that test. That test is very expensive and is no required. For the side effect, somehow, and then for elderly patient, Eliquis may be better than warfarin because they don't confuse. They are not confused with the dosage, so they take the Eliquis with the instructed dose, then they have no problem with the bleeding. But for warfarin, sometimes they confuse with the dose, and then they may take a wrong dose, and it will cause bleeding. That's one of the reasons. The second, based on the study, Eliquis may be better in terms of stomach bleeding, where to warfarin for the elderly patient. And then the Eliquis is, like I say, it's just like low enough injection, so you don't have to be breached before the surgery, because you may only need to hold for 2 days prior to the major surgery or procedure. But depend on the kidney function. If you have the bad kidney function, then you need to hold more than 2 days, like 3 or 4 days, depend on your kidney function. And the Eliquis, they only need to monitor the side effect, which is they need to bleeding. So they need to test your complete blood count to make sure the hemoglobin is not too low. If the hemoglobin too low, it means you might have some kind of internal bleeding. Then you need to pay attention on Eliquis, and then you need to go to see a doctor, the stomach doctor, to make sure it's not caused by the Eliquis. And then you need to check your when you're on blood thinner medication, you need to check your stool and your urine frequently to make sure any kind of bleeding. Check your skin to see if any abnormal bruising, those things. that you need to pay attention, and you need to avoid any physical activity that easily cause fall. So those things need to be counseled when you're on any kind of blood thinner medication. So Eliquis generally is maybe better than warfarin in terms of side effect, and then it's more convenient than warfarin because the dose is a fixed dose and do not require to um, test frequently, and they're not and the diet, vegetables, greens uh, do not affect Eliquis. So more convenient, and it might be better in terms of side effect for some people. The disadvantage is it's so expensive. Some insurance, some healthcare insurer, they don't pay for it. So you need to work out with your health insurance to make sure they cover. And if somebody worry about their therapeutic or their how the aliquots work in their body, how do they want to know if enough aliquots in the body or not. So if for some people like that, they might stick with warfarin. They don't want to try the medication. You know, if not, it does not need the blood test to make sure it's not too low or too high, like warfarin. And some people need to take Eliquis with a lower dose, like 2.5 milligrams twice a day. No people because they over 80 years old, and their weight is under 132 pounds, things like that. If they have those two factors, then they require to take a lower dose. If their kidney function, if their creatinine lesser than greater than 2.5, then probably they need to take a lower dose. For certain people, like people on dialysis, they may be not the best candidate for the Eliquis. They should stick with warfarin. So, if you have any further question or concern about if you are taking any blood thinner medication, please let me know in the comment below. some of my patients keep asking often, I know. So when you go to Google and go INA, this here is a basically go up INA or the range, full range of INA is between 2 and 3. Most indication for the mitral valve or electro heart valve INA 0.5 to 2. That's correct. But for the other special INA is 2.5 to 2.5 and not one way the but well. Sometimes people who have different thrombosis or DVT or the AFib that cannot be controlled by warfarin with the go-to. For example, people have been taking warfarin with the INA rank between 2 and 3, but still have stroke or still have recurrent DVT or PD. They may increase the INA range to 2.5 to 3.5. Make sure they not having stroke or the recurrent DVT or PD when they are at therapeutic level. And sometimes they have the patient additional medication like aspirin and the current DVT or PD stroke and take over. Sometimes very high risk of bleeding may want to have those patients a lower range, maybe have to be below 1.8. Sorry, maybe 1.5 to 2.5. So, for those people, they have risk of bleeding. Have any further questions? I'm going to talk a little bit about being careful for people who are on warfarin as a medication for certain medical conditions, DVTs, like different legs, or pulmonary embolism like PE, or AFib, atrial fibrillation. So for those people who have to take warfarin, most of people who have AFib and need to take the warfarin because they have certain condition like mechanical heart failure in their body. So, how concerned about the vitamin K food to warfarin and other oral anticoagulants like Alaplex, Geronto, or Bedaxa. So vitamin K does not affect other oral medication like Geronto, Alaplex, or Bedaxa. It does affect warfarin. So when you take, when you go to Google and you post and warfarin, you know, you can find some information about vitamin K food, what food contain vitamin K, and some foods contain more vitamin K, some food has less vitamin K. On Google, usually they have all the common questions like people also ask when you concerned about vitamin K and warfarin. So some question like, can you eat warfarin or warfarin?